So now we're going to talk about the muscles of the knee and functional considerations. So in the last chapter, we separated those out for the hip because there were so many muscles on the hip. But luckily, a lot of the knee muscles we've already talked about because they're shared with the hip. So we're going to talk about just the ones that aren't shared with the hip. So the hip ones still apply as knee muscles because we know that the hamstrings are all knee flexors, the quadriceps are knee extensors. Some of the adductors work as stabilizers. So those hip muscles, don't forget them. You still need to know those. But we'll talk about the knee muscles that don't cross the hip. So basically, we've talked about all the two-joint knee muscles that cross the hip. And now we're going to talk about the single-joint knee muscles and then one two-joint knee muscle that crosses the ankle. So as far as innervation goes, the femoral nerve supplies the sole source of innervation to the quadriceps. So femoral nerve injuries can be very they have a lot of functional impact because they can affect your walking and standing and getting out of chairs and whatnot because they innervate your quadriceps. Recently, I've worked with a fair number of people with femoral nerve injuries from different causes. Some of them from brain injury type causes, some of them from surgical complications, some of them, one person with a stab wound. So all sorts of cool ways to get your femoral nerve injury. No, not cool ways, but anyway, so a lot of things can affect your femoral nerve, and if your femoral nerve is affected, that affects your quadriceps. That's huge. So all muscles are important, but some are more important than others. Quadriceps, they're big boys. We're totally working on those guys in PT all the time. So when you have a femoral nerve injury, it's bad news for the quadriceps. The tibial portion of the sciatic nerve innervates the semitendinosus, semimembranosus, and the long head of the biceps femoris. We know them well from the hip, and there are some of our major knee flexors. So that's our tibial portion of the sciatic nerve. The peroneal portion of the sciatic nerve innervates the short head of the biceps femoris. So that's where we've peeled apart the headphones, and one goes the tibial portion, one goes the peroneal portion. Also, the short head of the biceps femoris, also a knee flexor. The obturator nerve innervates most of the hip adductor muscles. We already knew that from the hip chapter. And the hip adductor muscles have their functions at the knee as well. So we can basically divide the knee muscles into two groups. So with the hips, we have the flexors, the extensors, the abductors, and the adductors, and the rotators. Well, with the knees, we basically have extensors and flexor-rotators. So the muscles that perform our knee rotation, that little bit of rotation with the screw-hoe mechanism, they are usually flexors as their primary job, and they just moonlight as rotators. So even though the knee muscles all have important individual actions, a lot of times they work together, they work in teams to maximize movement control. So going from standing up from a seated position requires simultaneous activation of the quadriceps and hamstrings. So we did some of those functional movement analyses in lab where we're analyzing going from a seated to a standing position. So the hamstrings often, when you're going to standing, the hamstrings are working to extend the hips and the quadriceps are working to extend the knees. So they're teams, basically. They're teams that work in these functional positions. So the quadriceps, we already talked about the rectus femoris because it crosses the hip. The other three, the vastus medialis, vastus intermedius, and vastus lateralis, do not cross the hip. So the rectus femoris, just as a review, its proximal attachment is the AIIS, anterior inferior iliac spine. Distal attachment is the tibial tuberosity along with the other quadriceps. Its actions are knee extension and hip flexion, and it gets the femoral nerve like all the quadriceps do. The vastus medialis, its proximal attachment is the medial lip of the linea aspera, and the intertrochanteric line of the femur. It wraps around, so you look at that fiber direction, you can see it really well in this picture. It wraps around and attaches to the common quadriceps tendon and the tibial tuberosity via the patellar tendon. But it goes medially, and it has that wrapping line of pull. It does knee extension. That's its only job. The vastus medialis, it's an extensor. Sometimes you'll hear about the VMO, which is short for vastus medialis obliquus. And it's the distal portion of the vastus medialis where the fiber direction is oblique. And a lot of times that is functionally important with knee injuries. So we'll talk about that more in your orthopedics class. But just when people talk about the VMO, that's what they're talking about, just those oblique fibers at the distal portion of the vastus medialis. The vastus lateralis, its proximal attachment is the lateral lip of the linea aspera. So it's sort of the mirror image of the vastus medialis. The intertrochanteric line and the lateral region of the gluteal tuberosity. Really, all I want you to know for exam purposes is the lateral lip of the linea aspera. But these are big muscles and they have big attachments. The distal attachment, of course, like all the quadriceps, is the tibial tuberosity via the patellar tendon. The vastus intermedius, it is deep to the rectus femoris. Its proximal attachment is the upper 2/3 of the anterior femoral shaft, and its distal attachment, of course, is the tibial tuberosity, just like all the other quadriceps. All these guys get the femoral nerve. That's their only innervation. All of them do knee extension. The rectus femoris also does hip extension. It has 2 jobs. The other quadriceps only have 1, knee extension. Sorry, the rectus femoris does hip flexion. I hope I said that right. Rectus femoris does hip flexion and knee extension, and the other ones only do knee extension. So, we talked a little bit in the last section when we were talking about Q angle, about lateral tracking of the patella. So what's the big deal? What do we care about lateral tracking of the patella? It increases pressure and friction within the patellofemoral joint. And so pressure and friction, that could result in pain, inflammation, joint degeneration, and possibly even dislocation of the patella. So we are going to classify the factors that contribute to laterally tracking patella as intrinsic or extrinsic. So an intrinsic factor, it's something that's inherent to the knee itself, like a tight lateral joint capsule would be intrinsic, or a shallow patellar groove would be intrinsic. And extrinsic factors are coming from someplace else, like weak hip abductors, or things happening at your foot and ankle. Those are extrinsic to the knee, but all of those factors can affect the lateral tracking of the patella. So that's what we're going to start talking about in the groups this week is you're going to be assigned one of these factors. It might be intrinsic, it might be extrinsic, and you're going to do a little research to find out effective treatment strategies. And then next week, you're going to work on getting together a PowerPoint for that. You're going to turn the PowerPoint in, and then in the May lab, each group is going to present their PowerPoint. So it shouldn't take very long. It'll be just 4 or 5 slides, hopefully, about that. And the groups are going to be mixed between Pierce Lab people and Bellingham Lab people. And so the Pierce Lab people for a certain group will present their PowerPoint at Pierce, and the Bellingham Lab people will present that same one in Bellingham. So everybody will get to see all the PowerPoints. And also, because people are going to be uploading them to the discussion board, you will get to have all the PowerPoints. And what a lovely thing to have to study for the test, right? So, patellofemoral joint and deep squats. Not a day goes by hardly when I don't tell someone something about squat form. Just yesterday I was talking to somebody about that. But patellofemoral pain is usually caused or characterized by the inability of the patellofemoral joint to tolerate large compression forces. A lot of times we don't necessarily tell people to avoid squatting motions, but we want to avoid motions that put excessive compression on the patella. So like this guy in the picture, look how anteriorly his knees are going. They're way out over his toes. So the thing that I'm always correcting people on is I'm having them take their hips back so it moves the line of gravity back, and there's not so much compressive force through the patella. So if you want to try it right now, try a deep squat with your knees coming out past your toes, and then try it with your hips going back and don't let your knees come past your toes, and feel the difference in the patella. You can definitely feel the difference. So the next group, so we talked about the knee extensors, and now we're going to talk about the flexor-rotators. So the hamstrings are the major knee flexor-rotators. Semitendinosus, semimembranosus, and biceps femoris, both the long and the short heads, span the posterior thigh and perform knee flexion, and most of them perform hip extension as well, except the short head of the biceps femoris. That's the only one that doesn't do hip extension because it doesn't cross the hip. The other three do cross the hip, and the hip position affects their operational length. So we start to get into questions of active and or passive insufficiency depending on the position of the hip. So hopefully you got plenty of that in lab this time, and how the hip position is going to affect the function of the hamstrings. There's the little section in the module about the length-tension relationship in module 2, and that was specifically talking about the hamstrings. So also in the flexor-rotator group are the Gracilis and the Sartorius. So this is a cadaver picture of the Gracilis, Sartorius, and semitendinosus, the SGT, which form together into that common attachment, the pes anserinus, at the anterior medial aspect of the proximal tibia. It's such a weird picture. It totally reminds me of like the aliens in Star Trek Insurrection, the ones that were trying to mine the planet's atmosphere for something that was going to make them forever young, but I digress. So the Gracilis and the Sartorius provide stability to the medial aspect of the knee. So that's the problem with having a good memory. You remember stupid stuff as well as important stuff. So Gracilis and Sartorius both assist with knee flexion and internal rotation of the knee. And when we're talking about internal rotation of the knee, we're talking about internal rotation of the tibia on the femur. So distally, they go posterior to the medial axis of rotation, and that's what gives them a line of pull for flexion. If they were anterior to the medial lateral axis, they would have a line of pull for extension, but they don't. They go posterior to the medial, and you can see that really well in this picture. That's why I chose this picture, not because it looks like the aliens from Star Trek Insurrection. So the tendons of the Gracilis, Sartorius, and semitendinosus join for that collective insertion at the pes anserinus. So I told you a couple weeks ago that I had a kinesiology moment in the clinic, and here's where it comes in. So I had a patient that I'd been working with post total knee replacement. She was doing really well with her knee replacement, but she started having some pretty intense pain, and she's pointing right to the anterior medial aspect of her proximal tibia or her pes anserinus. So I palpated there a little bit, and I went up, and we found, wow, she was really super tight through her semitendinosus. We did some myofascial release there, and she had a semitendinosus strain, basically. So the thing that clued me in is that I knew where that muscle attached. It was a kinesiology moment, and it really helped her out a lot by working on that muscle. So a lot of times, after someone has had a total knee replacement, before their knee replacement, they may have had some misalignment in their knee. So some muscles were a little more shortened than they would be if the knee was well aligned, and some were a little more lengthened. So then they put in the knee replacement, they aligned the knee properly, so now we've got some muscles on stretch that maybe weren't on stretch before, and so you can see some muscle strain and sometimes some tendinitis after a total knee replacement, and it just takes a while for those muscles to lengthen out. But once again, kinesiology saves the day. We were able to help her because we knew where her attachment was. So the gastroc and the Plantaris, Gastrocnemius and Plantaris, are also in the knee flexor rotator group. So the gastroc is that big, powerful two-headed muscle that attaches on the femur and goes across the ankle. It produces large plantar flexion torques across the ankle, but because it crosses the knee there, it's also a knee flexor. And its line of pull pretty vertical, and it's posterior to the anterior, medial lateral axis, and so we have that line of pull for knee flexion. It's actually, the gastroc's a pretty powerful knee flexor. The Plantaris, relatively small, has the same line of pull. It crosses the posterior knee, but it's puny. Why would you use your puny Plantaris when you could use your giant gastroc for the same thing? Anyway, we'll call it the gastroc's little helper. So the Popliteus, its proximal attachment is the posterior aspect of the lateral femoral condyle, and the distal attachment is the posterior surface of the proximal tibia. You can see that the line of pull goes lateral to medial. When we see a lateral to medial line of pull like that, that tells us rotation, right? That's going to give us that medial rotation of the tibia on the femur when that muscle shortens. Makes sense, right? So it does that knee internal or medial rotation, and it also has a line of pull for knee flexion because it's that oblique line, so it's a little bit vertical, a little bit medial lateral, and it's posterior to the medial lateral axis. So we have that line of pull for rotation, internal rotation of the tibia on the femur, and knee flexion. The Popliteus is the muscle that initiates knee flexion going from a fully locked position. So I always say it pops the knee open. That's how I'm going to remember. It's the Popliteus. So that's the muscle that initiates knee flexion when you're going from that fully locked screw home mechanism knee position. So a lot of times hamstrings are tight. It can be due to spasticity. It can be due to muscle irritability, like my total knee replacement patient, or by spending an extended time in a flex knee position, such as sitting in a chair studying for kinesiology. The tightness of the hamstrings is often visibly observed by an inability to fully extend the knee. Extreme hamstring tightness can also lead to chronically flexed hips or a posterior pelvic tilt and a flattened lumbar spine. So we talked about that force couple between the hip extensors and the abdominals that flatten out the lumbar lordosis and cause that posterior pelvic tilt. So if you have tight hamstrings, that could pull you into a posterior pelvic tilt. Passive tension on the hamstrings could posteriorly tilt the pelvis. The pelvis needs to be stabilized during a hamstring stretch. So excessive posterior tilting can produce overstretching of connective tissues in the lumbar region, and it can produce a lot of stress on the discs. So the rectus femoris and the hamstrings, they're working a lot together. One of them is stretched while the other one is contracted, or vice versa. Most of our functional lower extremity activities combine hip flexion and knee flexion, or hip extension and knee extension. For example, sit to stand. When we sit down, our knees are flexing and our hips are flexing. When we stand up, our knees are extending and our hips are extending. So the rectus femoris and the hamstrings have to team up, basically, to make sure things happen the way they're supposed to. So during combined hip and knee extension, both the rectus femoris and the semitendinosus avoid maximum shortening across the hip and the knee to prevent muscles from becoming actively insufficient. So when we extend both the hips and the knees, we avoid insufficiencies. When we flex both the hips and the knees, we avoid insufficiencies. So a lot of our functional movements, just kind of tune into your functional movements this week and say, Am I potentially reaching a position of active or passive insufficiency? And chances are you're not, because of the way these things are set up. For internal and external rotators of the knee, like I said before, that it's not necessarily a voluntary motion, but it's something that happens with other motions to maximize our knee function. So the hamstrings, the gracilis, the popliteus, and the sartorius control active rotation of the knee in the transverse plane. So those are like there are knee rotators. The medial hamstrings, gracilis, and sartorius internally rotate the knee, where the lateral hamstrings externally rotate the knee. And again, we're talking about internal rotation of the tibia on the femur or lateral rotation of the tibia on the femur. So it's helpful to specify what's rotating on what, because it's hard to get your head around internal and external rotators of the knee. Actually, when I was in school, they used to talk about the knee as a hinge joint and never even talked about rotation. Maybe talked a little bit about the screw home mechanism, but didn't talk about using muscles to do this. And so the first time I read this, it blew my mind. I'm used to it now, and it makes a lot of sense. So the internal rotator muscles at the knee far outweigh the strength of the external rotator muscles. So a lot of times we're having to accelerate the knee into internal rotation or decelerate the external rotation by eccentric activation because we're trying to stabilize the knee into extension. That makes sense, right? We're trying to, like we're standing on the bus and we're trying to co-contract everything to keep from falling. Or we're trying to stabilize with our knees straight. Or we're trying to stabilize the knee as we step out and accept our weight onto that front foot. So accelerating the knee into internal rotation stabilizes it by locking into that screw home mechanism. Okay, so the stability of our knee is maintained largely by ligaments. We got those big beefy ligaments and those big beefy muscles and tendons surrounding. We don't have a lot of bony stability, so we have to have our muscles and ligaments doing it for us. Combinations of large forces and lack of bony constraint might be the reason for high incidence of knee injuries. And I'm telling you, when you work in PT, you see knee injuries. That's very common. Rehabilitation approaches usually involve the knee itself, meaning strengthening the knee muscles, working on knee motion, stretching the knee muscles, as well as working on feet and ankles and hips. So the surrounding joints and muscles are very involved in knee alignment, and so a lot of times in rehab, we're not just working on the knee. You're doing your patients a disservice if you don't also work on the hip and the ankle.